بسم الله الرحمن الرحيم. الصلاة والسلام على رسول الله. Hi everybody. I would like to thanks all of you for joining us this evening with the second Saudi Society for Clinical Chemistry Journal Club for 2021. I'm Anwar Burai. I'm a clinical scientist, National Guard Hospital. I have today two guests from the National Guard Hospital from Jeddah to present the second Saudi Society for Clinical Chemistry Journal Club meeting for tonight. I would like to thank everybody for attending this journal club and for those who are interested in this important topic about parathyroid hormone. The first speaker today will be Dr. Abdullah Baha. Dr. Abdullah Baha completed bachelor degree in medicine and surgery at the Faculty of Medicine at Tumor University in 2014. At 2018, he got the Saudi Board in Pediatric Medicine in National Guard Hospital in Jeddah. At 2020, he completed his pediatric endocrinology fellowship training program in National Guard in Jeddah. Today, he is going to present the topic of parathyroid hormone overview. And I hope you enjoy within the next 30 minutes his talk, and inshallah, Dr. Abdullah, can you share your presentation, please?
Okay, thank you, Dr. Anwar. Assalamu alaikum, welcome everyone. And I will talk today on parathyroid hormone and overview. So this is the point of my presentation. I will talk about definition, anatomical location, metabolism, action, clinical presentation, pathophysiology, physiology, and parathyroid hormone-related protein. So when we start with the definition, it's an endocrine hormone synthesized and secreted by chief cell of the parathyroid gland that regulate the serum calcium concentration through its effect in bone, kidney, and indirect through intestine. The anatomical location, the parathyroid gland is contained of four small glands located posterior to the thyroid in the middle aspect of the anterior neck. The parathyroid hormone, it's a polypeptide that is cleaved into an active form within the parathyroid gland. The initial structure formed is a pre-parathyroid hormone, 115 amino acid polypeptide that it's cleaved to form a parathyroid hormone containing of 90 amino acid and is then cleaved a second time again to at the amino terminal site to form active parathyroid hormone containing of 48 amino acids. Metabolism. Active parathyroid hormone secretion can occur as quickly as a few seconds when low serum calcium is detected, and as we see that the range of the calcium is very narrow because of this. It's as a very it's very important system and need the calcium. It will be its a normal range. The serum half-life of the active parathyroid hormone is less than 5 minutes, and in some reference mention it's around 2 minutes, and it's removed from the serum quickly by the kidney and the liver. And from our side, we can use this in the surgery to remove a parathyroid or parathyroidectomy with adenoma and carcinoma. We can send the parathyroid hormone at the time of the surgery to see it's removed or not, the adenoma. So we'll go to the action. Usually, when in the blood with low calcium level, they will they will less attach to the calcium sensor receptor. It's found in the parathyroid glands, and less activate of calcium sensor receptor will lead to increase the parathyroid hormone. Parathyroid hormones directly go to the bone, increase bone resorption, which lead to increase the calcium to the blood, and also go to the kidney, which increase the calcium reabsorption by the kidney and increase phosphate, decrease phosphate reabsorption or increase phosphate excretion, and activated the active form of vitamin D 125 dihydroxy cholecalciferol, which go to intestine and increase the calcium and phosphate reabsorption, which all lead to high calcium. Also, from this picture, we will know that uh, parathyroid hormone controlled by calcium level, controlled by phosphate level. When we have a high phosphate in the blood, which lead to increase the parathyroid hormone, and also will increase with decrease or deficiency in vitamin D. This is regulated by calcium level through the calcium sensor receptor, phosphate level, calcitrol active form vitamin D, and magnesium level also act on secretion of parathyroid hormone. The pathophysiology, we have either hyperparathyroidism, high parathyroid hormone, hypoparathyroidism, low parathyroid hormone, pseudo hypoparathyroidism, and I will talk about all of these. But before we talk, we need to know the clinical presentation. Most of our patients, they become either with hypocalcemia or hypercalcemia. Hypocalcemia, like numbness of the hand, feet, slip, muscle cramps, spasm, seizure, facial twitching, muscle weakness, a slow heartbeat, or psychomotional symptom like anxiety, depression, hallucination. Hypercalcemia, on the other hand, they come with loss of appetite, nausea and vomiting, constipation, abdominal pain, flank pain, hematuria, polyuria, tiredness, weakness, or muscle pain, hypertension, headache, depression, and also change in mentation can progress to coma. So let's start with hypoparathyroidism, low parathyroid hormone. All of the patients, they present with hypocalcemia. The causes can be surgical remove by accidental remove with thyroid surgery, or maybe auto destruction by autoimmune, like for example, autoimmune polyglandular syndrome, radiation therapy, or can be infiltration, cancer, metastasis, infiltration, iron. All of these lead to hypoparathyroidism, or some causes can impair parathyroid secretion or action by magnesium deficiency, which lead to impaired secretion and action of parathyroid, and also high magnesium, hypermagnesemia, will act on the calcium sensor receptor and will affect on the parathyroid secretion. This is common in pediatric, more genetic defect of parathyroid synthesis and parathyroid gland development. Usually, it can be isolated or can be symptomatic. Symptomatic, we have a very common disease. It's a syndrome. It's Digeorge syndrome. Other common syndrome we have here in the Middle East, it's a Sanjay Zakati syndrome, or in some reference mention, it's a Middle East syndrome. Usually, those patients present with severe failure to thrive and dysmorphic features you see in the picture, and they have hypoparathyroidism and even difficult to treat. In our center, we have around 5 or 6 cases. Usually, the management of hypoparathyroidism, it's a calcium supplementation, vitamin D supplementation with calcitrol, active form of vitamin D, because yeah, as we mentioned, the action of parathyroid is work to activate the vitamin D, and careful monitoring serum calcium phosphate and urine calcium. So on the other hand, we go for hyperparathyroidism or high parathyroid hormone. Usually we divide into 3 types. Primary hyperparathyroidism, those patients present with hypercalcemia and usually due to parathyroid adenoma or hyperplasia. And secondary hyperparathyroidism, it's like a compensation mechanism due to the decrease of the calcium level, and most of the patients they have hypocalcemia, and due to vitamin D deficiency, 1-alpha hydroxy type of vitamin D deficiency, and hereditary vitamin D resistant rickets, and other chronic renal disease, malabsorption, malnutrition, and medication. Tertiary, it's complicated from the secondary hyperparathyroidism when the body try for a long time produce parathyroid hormone as a compensation and the parathyroid become hyperplasia, and then even after that when control the calcium level, the parathyroid is not stopped. It's common with the patient with a renal failure. For the management, it's depend on the type and the cause, but most of the primary and tertiary hyperparathyroidism, usually they need surgical treatment, parathyroidectomy, with after that requirement a replacement of the calcium and vitamin D. Secondary hyperparathyroidism depends on the cause, calcium supplement and vitamin D supplement. What about pseudo hypoparathyroidism? Is a condition associated primarily with resistance to the parathyroid hormone. Those conditions, they have low serum calcium, high phosphate, and the parathyroid hormone level is appropriate high, but it's not function. Its pathogenesis has been linked to dysfunction of G protein. Usually, pseudo hypoparathyroidism can present with the point or with the defect in parathyroid, and can present also with some type with dysmorphic feature. And this dysmorphic feature called Albright hereditary osteodystrophy. Patient usually short, obese, they have round face, they mentally retarded, and they have small hand and feet. Last thing I will talk about parathyroid hormone related protein was originally discovered as a cause of hypercalcemia of malignancy. Parathyroid related protein then they discovered that play a significant role in regulate skeletal development and fetal calcium homeostasis, and its widely expressed in tissue included cartilage, smooth muscle, central nervous system, and other. Its share a parathyroid hormone 1 receptors in the kidney and bone through its amino terminal. For me, I think the main difference, and in this sentence, although the parathyroid hormone-related protein is found in the serum, a majority of activity appear to reflect a paracrine signal. So parathyroid-related protein, it's a paracrine, it's work locally, except in malignancy, when it's become high, it's work like a parathyroid. So I hope you are it's I try to be specific and be small lecture to understand. Thank you.
Thank you, Dr. Abdullah, this overview, and I think you covered almost most of the important points need for any person would like to know about parathyroid hormone. I would like to remind all the attendees that registrations regarding CME hours, after this journal club, you will receive an email from the Saudi Society with the link. So you can go to that link and register your name and register your Saudi Commission license. So your CME hours will be accounted. Regarding the questions for this journal club, we'll leave it at the end of the second presentation, which will be by Mr. Haytham Khalil. So we'll take now the second presentation. Mr. Haytham Khalil, he got his bachelor degree in medical technology in 2013 from King Abdulaziz University. and he got his master's degree in clinical chemistry in 2020 from King Abdulaziz University. His topic will be about stability and validity of intact parathyroid hormone levels in different samples types and storage conditions. I hope you will enjoy also with Mr. Haytham in this important topic as he will go through this important points that we as a lab technologists need to go through them and need to know about them and the effect of different conditions on parathyroid hormones levels in clinical laboratory. Thank you, Dr. Abdullah. And inshallah, we'll join. You can join with us at the end of this second presentation.
Okay.
You can go ahead, share your slides, Haytham.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Anwar, for your kind introduction, and thank you, Dr. Baha, for your nice presentation. In this lecture, I will talk about the stability and validity of intact parathyroid hormone levels in different sample types and storage conditions. In 2015, and specifically in one of our research that conducted in King Abdulaziz Medical City in clinical chemistry lab to establish the reference range of clinical chemistry analytes for the adult population in Saudi Arabia, we observed that more than 300 of 826 results of intact parathyroid hormone considered as hyperparathyroidism if we depend on the reference range provided from the company. And this was very confused issue for us because all those patients were not suffering from any symptoms of hyperparathyroidism. And later, from our practical observation, we observed that sometimes intact parathyroid hormone tend to be higher in serum than EDTA plasma. So simply one question came to us, are these abnormal results due to different population that used to establish normal range provided from company, or due to using different tube types? So let's go with the small introduction and about the anatomy of the parathyroid gland. There are 4 glands that are located in the posterior of the thyroid gland, and its function is to synthesize and secrete the parathyroid hormone by formation of pre-parathyroid hormone, which is 115 amino acids synthesized in the ribosome of the sheath cells, and then this pre converted to pro-parathyroid hormone, which is 90 amino acids. Then it is converted to intact parathyroid hormone, which is the principal form, goes to the blood circulation and do the function to increase calcium level in the blood, and it is the biological active form. In the blood circulation, there are many fragments of parathyroid hormone because parathyroid hormone is subjected for fragmentation in the blood circulation. We have 184 parathyroid hormone, and also we have 784 parathyroid hormone, which lacks the first 6 amino acids near from N-terminal. This type of parathyroid hormone accumulates in patients with chronic kidney disease. Also, we have amino parathyroid hormone and C-terminal fragments. So let's go to the lab. Parathyroid hormone test can be detected in the clinical laboratory and by using 2 methods. For the reference method of detection by using liquid chromatography mass spectrometry but unfortunately, actually, this is the reference method of parathyroid hormone detection, but always you can find it in reference lab or research lab. The other method is to detect parathyroid hormone by using immunoassays. In the market, we have 3 generations of parathyroid hormone tests. The first generation is used to detect parathyroid hormone by using radiolabel immunoassays technology. Second generation is used to detect parathyroid hormone by using more advanced technique or technology such as ELISA or chemoluminescence. The same thing with the third generation. So what is the difference between first and second and also third generation? For the first generation, the problem with this method is inability to differentiate between C fragments and full biological active sequence, while the second generation has an antibody specific for the C fragment for capture and another antibody specific for the full biological active sequence for the detection. The third generation has an antibody specific for the first 6 amino acids near from N-terminal, so it can detect the amino parathyroid hormone. Generally, the outstanding of clinical laboratories is the consistency of producing reliable results. Some analytes, if you work in the lab, some analytes are strong and stable. Some are quite strong and not very, very stable. And some are very, very weak and can be affected by different factors that can be encountered in the clinical laboratory, such as transportation from phlebotomy area or from wards to the main lab, and the type of tube also, delay before centrifugation, and storage conditions. In the literature review, we found that intact parathyroid hormone stability took a wide range of studies, but we have found much variabilities in their outcomes. Some of them are outdated or contradicted each others. Moreover, no one study included all these factors that can be encountered in the lab in one single study. I will not talk about the previous studies, but I will talk about the most recent one. Hannon et al. In 2013, they did the systematic review about parathyroid hormone stability because of this contradiction in the previous studies. They suggested that room temperature parathyroid hormone is stable for 1 day as a whole blood in EDTA tube, and is stable up to 2 days as a plasma EDTA. They observed the reduction in the parathyroid hormone level occur if the sample delayed in the centrifugation for 3 hours, or delayed in the processing for up to 2 hours. Also, they suggested that refrigerated parathyroid hormone is stable for up to 3 days as plasma EDTA and up to 1 day as a serum. They did not suggest anything about freezer condition due to limitation in the previous studies. Actually, the problem with this study, it is only systematic review. It is not an experimental method. So we aimed to investigate intact parathyroid hormone values in plain serum separator tube and EDTA tube to evaluate the effect of delay in the separation of plasma from red blood cells or serum from clots on intact parathyroid values, to assess the stability of intact parathyroid hormone at different time intervals using several storage conditions, namely room temperature 4 and -20 degrees. Therefore, we want to make a recommendation for the standardization of type of tubes. processing and storage conditions. So let's go to the methodology. We have divided our samples into two sets. First set, 30 participants have participated in our study, and we have collected 3 types of tubes from each, namely plain serum, ADTA, and serum separator tube. And we centrifuged all type of tube immediately, and we measured intact parathyroid hormone immediately after centrifugation. Then we allocated the remaining volume, and we stored in room temperature, freezer, and fridge. Then we measured the intact parathyroid hormone at day 2, day 4, and day 8. For the second set, the samples are delayed in separation for up to 2 hours for EDTA and plain. Then after this delay, we did centrifugation, and we measured intact parathyroid hormone. Then we compared these values to the baseline, the fresh status. We set minus 30 as a clinically significant, depending on CLIA. We measured parathyroid hormone by using chemoluminescence Architect I2000. So let's see our results. To investigate the effects of tube additives on intact parathyroid hormone values, one-way ANOVA shows that there is no significant difference between the 3 types of tubes. As you can see here, p-value is 0.95. To investigate the effect of the delay in the separation, paired t-test was done to see the significant. And as you can see, there is a statistically significant difference between delayed samples when compared to immediate separated samples for both serum and plasma. But the mean difference percent change is minus 7.37 for the ADTA and minus 3.77 for the serum. To investigate the effect of storage conditions on plasma intact parathyroid hormone, ANOVA with repeated measures was conducted to investigate this issue. Overall, there is a statistically significant difference at all days in all storage conditions when compared to fresh status, but the mean percent change is exceeded the total allowable error in only day 8 for room temperature. Investigate the effect of storage conditions on serum intact parathyroid hormone. Also, ANOVA with repeated measures was conducted to investigate this. Overall, there is a statistically significant difference between the values in all days, in all storage conditions when compared to fresh status, but the values only exceeded the total allowable error, where in room temperature in day 2, 4, and 8. This figure shows you the decrease in the percent change from 0 time or from the baseline to day 8. As you can see here, day 8 in room temperature is exceeded the total allowable error of minus 30% only in room temperature for EDTA plasma, while the serum exceeded the total allowable error in room temperature at day 2, day 4, and day 8. Regression study. What is regression study? Regression study is the statistical tool that can be used to predict or to anticipate the period in the future In our study, we did our experiment up to day 8, but we can use this method or this statistical tool to anticipate what will happen in day 9 or 10 or after that. So actually, I did not do it for the room temperature because all values exceeded the total allowable error at day 8. But here in for EDTA plasma, for the fridge condition, you can see the values exceeded, or the percent change exceeded the total allowable error at day 11, while in freezer it exceeded the total allowable error at day 10. For the serum, it is exceeded the total allowable error when used fridge condition as a storage at day 9. But for the freezer, it is exceeded the total allowable error at day 16. So let's go to discussion. In clinical laboratories, as you know, if you work in clinical laboratory, you will know that many analytes can be affected by different factors such as type of tubes, transportation, and storage conditions. Although many analytes are stable and can remain stable and not affected by these factors, but others such as parathyroid hormone are very sensitive and can be affected the factors mentioned above. We found in the previous study much variability regarding the tube that can be used to measure intact parathyroid hormone freshly. Actually, the optimum protocol in the clinical laboratory to do any test immediately, but this cannot be guaranteed or cannot be achieved by many laboratories due to many factors such as budget or any other factor. So we investigated the effect of tube additives on intact parathyroid hormone, and we found that no significant difference between the 3 types of tubes. Although previous studies suggested that EDTA plasma is only the tube that can give reliable results for the intact parathyroid hormone. Our finding is different than them because could be due to using different instruments in our study. In the actually, one previous studies, interestingly, suggested that serum and EDTA results are different in one analyzer, but showed no difference by other analyzers. So maybe intact parathyroid hormone based on an instrument issue. Why it is important to investigate the parathyroid hormone in the different type of tubes? Because it gives freedom in choosing types of tubes, and also for the unification of one tube for many tests. For example, if the physician order bone profile and he wants also to investigate or result for intact parathyroid hormone, so he can include all tests together, and this can minimize the blood taken from the patients. So our second factor is the delay in the centrifugation. As you know, time of separation after collection may challenge producing reproducibility. We have investigated the effect of the delay in the centrifugation on serum and EDTA sample. And there is statistically different when compared to fresh, but clinically, the mean percent change didn't exceed the total allowable error. Why this is important? Because many dialysis centers and outside clinic are located far from the hospital, and they send their sample to the hospital. So this can make sure the physician that no clinically significant change will occur to the intact parathyroid hormone due to transportation. The last factor we studied is the effect of different storage conditions on plasma and serum intact parathyroid hormone, and also the other factors at different time intervals. So we have 2 factors in this study also. We found significant difference overall in all days at all at all days in all different storage conditions. I will take it in details one by one. For room temperature, serum exceeded the total allowable error in all days, while plasma exceeded the total allowable error in day 8. Our result confirm actually the previous studies finding that said EDTA plasma parathyroid hormone is more stable at room temperature. For the fridge, no percent change in all subsequent days have exceeded the total allowable error. Previous studies suggest storage can be used or up to 24 hours. The difference between our finding and them is very clear because we have choose the total allowable error larger than them. We used 30%, but they used 12.5 desired analytical error. For the freezer condition, yet again, the percent changes didn't exceed the total allowable error of 30%. One previous study suggests up to 5 days. Our result further extend that period for up to 8 days. Why it is important to investigate the effect of a storage condition? Because actually to produce reliable results and to minimize the chance of error, give a freedom of choice to choose which one you can choose it in the clinical lab to save the sample. If you are not going to do this is at the same moment, the IPTH at the same moment. Also, budget management. Limitation. Our study is limited to a specific type of an instrument, Architect I2000. Also, it is limited to a specific tube company. And also, we did our study on a healthy individual. Our recommendation, intact parathyroid hormone can be performed immediately after collection using EDTA plasma serum from Gland or serum separator tube. EDTA or serum samples can be reached to the lab within 2 hours of collection. Room temperature cannot be used for serum. It is acceptable up to 4 days at room temperature using EDTA plasma. Freezer and fridge temperature can be used up to 8 days. Intact parathyroid hormone result may be based on pre-analytical and instrumental factors. Finally, to expand awareness about the importance of such variations and to strive for better reproducibility and stability, we recommend that this study can be repeated on other commonly ordered crucial analytes in diagnostic laboratory. And finally, in 2021, this research is published, alhamdulillah. You can find it here. Thank you for listening. I hope this was, thank you very much.
Thank you, Mr. Haytham. Very interesting presentation for this important topic, which is the parathyroid hormone, which is a very well-known hormone about its stability and storage conditions that we are encounter in the clinical laboratory in general. Thank you, Dr. Abdullah, and thank you, Haytham. I think I can receive or I can mention some questions here for Mr. Haytham. Do you think that the number of 30 subjects is low regarding such a study for validation of parathyroid hormone?
Actually, before we decide to take this number of 30 samples or 30 participants, we did the effect size statistically, and it was I think it was enough number to do this, and we have the significant also.
Okay, you mean the Empower study was enough to investigate parathyroid hormone stability with such a number?
Yes.
Yeah, in addition to your comment, I think such a study, as a repeated study, they call it repeated study. The number is a limited number of samples. For about 30 or 40 samples will be enough. More or less, even you can check other studies. Sometimes a less number of 30, of less than 30, you can utilize for investigating stability as long as the samples exposed to the same or same conditions at the same times. So this kind of study of repeated studies in time intervals is well known regarding the low number of samples. So 30, 40, 50 will be enough samples to investigate your analyte for stability study.
Exactly. And in addition, if I can add more, also the statistical method we used in this study was ANOVA. So I think it is also a very strong statistical tool that can be used to see the difference between means or variance.
Okay. Thank you, Mr. Haytham. Dr. Abdullah, there is a question here. It says, can the parathyroid-like protein be exploited for therapeutic use? Do you think if there is any studies done before about this topic?
Actually, no, I didn't hear. يعني some study they use the parathyroid hormone, but again, يعني most of the study they didn't found it's effective like other medication. يعني parathyroid hormone used in osteoporosis. يعني the as we know, it's a يعني it's if you use the chronic use, it's lead to decreased bone density, osteoporosis. But if you give as intermittent, it increase the bone density. So they use on osteoporosis, but now there is a lot of medication better than parathyroid hormone. So most of the study that try to use parathyroid hormone. Parathyroid related protein, no, there is no. Even it's difficult to measure the parathyroid protein, but no, it's not used for therapeutic.
Okay, thank you. There is another question, Mr. Haytham. It says, may I know what is the recommended tube for BTH testing from your conclusion?
The recommended tube, if you want to measure intact parathyroid hormone immediately after collection, you can use EDTA plasma, serum separator tube, and plain tube. All of them you can use it. But if you delay in the centrifugation, also you can use both. As you saw, the mean percent change didn't exceed the total allowable error when we kept the samples at room temperature as a whole blood for 2 hours. So 3 types of tube can be used immediately. It's okay.
Another question, Mr. Haytham. It says here, what is the recommended blood tube from the manufacturer? I think the manufacturer in your study regarding
yes,
the BTH assay, is it Abbott?
Yes, Abbott. We used Abbott, yes, Architect I2000. The recommended tube was EDTA plasma and serum separator tube, and also serum from plain tube. But as you know, this company, when they do their study, they have specific environments. So we need in our lab to do our study to confirm. And also, when we looked at the previous study, we found that many contradictions regarding the tube that can be used for detection of intact parathyroid hormone.
In continuing with the same question, would it be better to use heparin blood tube rather than EDTA?
In our study, we didn't actually investigate this, but I think in the insert sheet, I read this. I think yes, you can use it, but it's depend on your analyzer. Just see the recommendation from the company.
Okay, thank you. There is another question here. It's talking about parathyroid hormone, using parathyroid hormone in point of care testing with the capillary sample to be used in endocrinology clinic and dialysis unit. Is any company working on this? I think I can answer this question. There is many companies have parathyroid hormone as a point of care testing, but the problem that these companies not certified. Parathyroid hormone is a sensitive hormone with a small molecular weight. This small molecular weight is the challenge for measurement of the parathyroid hormone and for the measurement of parathyroid hormone in whole blood. And that's the reason there is no certified point of care testing until now. So we need to be careful. I would like to advise all the users or all the lab technologists that whenever you found parathyroid hormone as a point of care testing to be utilized in intraoperative procedures, be careful about the quality of the point of care testing device which should be in these situations. As according to my knowledge, that there is no certified companies until now producing point of care testing for parathyroid hormone. There is a question here. The study was done on normal subjects. What about the variation at medical decision level? We need to look at that too.
Yes. Yeah, I think we need to look at this also. But when I read previous studies, they did actually on hemodialysis patient, and some of other studies they did on healthy individual. The suggestion from both was the same. I don't know, but we need to study this really. Actually, I don't know if will any difference will be or not.
I think in addition to your study, I think one of the challenges you encountered in your study, Mr. Aitam, is that the collection of the sample from 30 subjects at the same time. That was a challenge, I think. How did you overcome that challenge? Because collecting the sample should be done at the same time,
Yes.
almost 1 hour in between. The maximum variation between the collected samples between those 30 subjects. I think. How did you overcome that problem?
As you said, Dr. Anwar, yes, it was very difficult to collect 30 samples at the same moment, but we did this to avoid variation, technical variation, and also to avoid change in the temperature and for the storage condition, or for difference in the centrifugation or temperature of the centrifuge.
Dr. Abdullah, there is a question here. Thank you, Dr. Abdullah, for your summary. Please, how common you come across parathyroid patients? Yet to come across on. Is it common to see in the clinic, Dr. Abdullah, to see patients with parathyroid hypo or hyper?
As endocrinology, yes, طبعا common, يعني at least in 1-2 patient in the clinic. But hypo, يعني parathyroid hormone, usually we use it as diagnostic test. يعني that usually first time, second time. But some disease, rare disease like vitamin D resistant ricket, usually we need to monitoring the patient. Usually those patients, they require calcium for long. They don't have vitamin D. It's not working. So they need a IV calcium for a long time, maybe for 1 month, 2 months, and then every week. So we need to monitoring parathyroid hormone in those patients to make sure a level less than 100. We don't know. In those patients, parathyroid is very important. But most of the patients we use as diagnostic only test. If we diagnosed, we depend on calcium and phosphate level after the treatment. But yes, a lot of patients hypoparathyroidism in the clinic, they come mainly hypoparathyroidism. We have a lot of patients. Every clinic we have 1 or 2 patients come.
You mean hypo is more common than hyper?
Yes. Hypoparathyroidism more common than hyper. In pediatric, yes.
Okay. Other question here. There's a question here. I don't know if I can understand what you must select patient with previous high BTH and patient with normal BTH level to compare the decrease in BTH level affected by storage. As I said, as Mr. Haytham said in his answer his question, that his patients, the volunteers were normal. All 30 volunteers were normal, and they also did you investigate their vitamin D level, Mr. Haytham?
Yes, Dr. Anwar. To confirm that our patients are normal, we did bone profile and vitamin D for all patients. And all of them were normal.
Okay. I think I can stop here because I don't have any more questions. Thank you so much for both speakers. It's very interesting topics, and thank you for all the efforts and time you spend to give these presentations to our audience. Also, I would like to thank the Saudi Society for Clinical Chemistry for organizing this event, and hopefully that you get a benefit, for all attendees get benefits from these 2 presentations, and inshallah we'll get more and more journal club in the future organized by the Saudi Society for Clinical Chemistry. This journal club is from King Abdulaziz Medical City, National Guard Hospital from Jeddah. Inshallah, we'll see you again in another journal club. And as I said, I hope if you can, regarding your CME hours, you will receive email to get a link. In that email, get the link and register your name, your Saudi commission license, and then you will get the 2 CME hours from this presentations. Thank you so much for all of you, and I hope you enjoy your night. Inshallah, we'll see you again in another journal club. Thank you so much. Thank you, Haytham. Thank you, Dr. Abdullah.
Thank you, Dr. Omar.
Thank you, Mr. Ali, for controlling this live event. Thank you.